Hi, everybody. Thanks for joining us tonight for Arthritis Talks. The topic tonight is knee arthritis, a very specialized topic, but a very relevant one. My name is Sean Brady. I'm the Vice President of our Arthritis Rehab and Education Program, as well as Innovation at Arthritis Society Canada. I'm also a physical therapist by clinical background. Really excited to be here tonight and facilitate the session. And while we have come together for this event from many different places, I would like to acknowledge that the land on which I am located and on which our Toronto office stands is the traditional territories of the Mississaugas of the Credit First Nation, Anishinaabe, Huron-Wendat, and Haudenosaunee Indigenous peoples. And today, this meeting place is home to many First Nations, Inuit, and Métis peoples, and I am grateful to have the opportunity to live with my family and work on this land. Arthritis in the knee can cause unbearable pain and significantly impact quality of life, especially without the right treatment. Fortunately, there are options that can help manage the disease, and tonight we are very fortunate to have Dr. Mark Roberts join us. Dr. Mark Roberts is an orthopedic surgeon. We also have Cynthia Roberts joining us, and Cynthia is a registered physiotherapist. They will both share their insights into knee arthritis today. And before we get started, we just want to go through a few logistics. This webinar is best viewed on a laptop or desktop computer. At any time, if you have technical difficulties, please email arthritistalks@arthritis.ca for assistance. And I think some of these details will be shared in the chat as well. And if you have a question for our presenter, you could submit it through the Q&A button on your Zoom platform. It's probably in the middle of your screen, bottom middle, and we'll try to get to as many questions as possible during the hour that we have together. You can also click on the chat icon in the bottom middle of the screen to access the chat and connect with other participants and our moderator as well. And if you would like to close the chat completely, just click on the X at the top, and that'll close out that window and give you a full view of the presentation today. To enable closed captioning, please click on the show captioning icon in your controls toolbar at the bottom of the screen. Now, we did receive many questions in advance that followed similar themes, so we are going to try to address those questions first in our live Q&A, but we hopefully will have time for some of the questions that emerge throughout the presentation. Before we get started, I would also like to thank our event partners, Pfizer, United Way Winnipeg, and our other partners for their financial support of our Arthritis Talks series. Okay, now we can get started. And a really warm welcome to today's experts, Dr. Roberts and Cynthia. Welcome. Thanks for joining. And Cynthia, maybe we'll start with you. Could you start us off tonight by chatting more about the early symptoms of knee arthritis?
Absolutely. Thank you so much, Sean. It's my absolute pleasure to be here tonight. First of all, I just want to mention there are many different types of arthritis. Some are inflammatory in nature, while the most common type, osteoarthritis, is degenerative in nature. Osteoarthritis involves a breakdown of the cartilage that covers the ends of the bones and usually progresses slowly over a period of months or even years. Initially, the symptoms tend to be intermittent, meaning that they come and go. Later on, they may become more constant. Usually, the physical symptoms are the first things that people notice, and often it starts with pain. This could be pain during or after activity, but over time, the pain can become more unpredictable, occurring even at rest or while sleeping. Pain is also incredibly complex and is influenced by what is happening both inside your joint as well as other things outside the joint, such as your muscle strength, your mood, your sleep, and physical activity. Interestingly, there is really no correlation between the severity of the osteoarthritis on X-ray and the severity of the pain that you might be experiencing. Pain from arthritis can occur anywhere around the knee joint, including under the patella or behind that kneecap sometimes. Stiffness is another really common symptom that people report, and even a loss of range of motion in the joint at times. Usually the stiffness occurs after a period of not moving for a while, like in the mornings, after sleeping, or when standing up after prolonged sitting. Typically, the stiffness in osteoarthritis lasts 30 minutes or less. In the inflammatory types of arthritis, it could last for an hour or more. Swelling is also really common. You might notice an increase in size of your knee because of that extra fluid. It may occur in a very specific location around the joint, and sometimes it's the whole thing that will be swollen. It is not uncommon to have the fluid collect at the back of the knee, which is also known as a Baker's cyst and is really just another symptom of the arthritis. Crepitus. This is the medical word for the grinding, the crunching, the creaking, popping, snapping, all those weird and wonderful, strange noises we can sometimes hear in our joints when the cartilage is not so smooth anymore. Instability can occur on occasion. People may notice their knee buckling or giving way. Sometimes this is due to pain. Sometimes it's due to weak muscles around the joint. Sometimes it's due to ligament laxity or looseness in the ligaments. And sometimes it's due to another problem in the meniscus. And then lastly, you might notice alignment or bony changes. So the knee might take on a bit of a knock-kneed shape or a bow-legged shape. Either one of those can occur. Because of the physical symptoms, you may start to see some limitations in your function throughout the day. So the pain might limit your ability to stand or walk for prolonged periods of time. Maybe you have difficulty climbing stairs, getting up from a sofa or a toilet seat, especially if it's low. Often squatting or kneeling are practically impossible for people with knee arthritis. I also want to take this time to highlight the psychosocial impact that arthritis can have. So all of these different symptoms and functional limitations can cause you to feel irritable, worried about the future, upset about the inability to do things that you used to love. Mental health concerns, including depression and anxiety, are more common in people living with chronic pain. I also want to highlight that the arthritis symptoms might interrupt your sleep or prevent you from falling asleep, which in turn can make your symptoms feel worse and reduce your ability to cope. And lastly, fatigue. It is really common for people with severe pain from arthritis to have high levels of tiredness or exhaustion, and this can limit participation in activities and social interactions. Now, with our clients, we often talk about the pain cycle. And this illustration shows some of the different factors that can influence our experience of pain and how all of these factors are interrelated. For instance, when we're fatigued or tired, we do feel our pain more intensely. We're also more likely to avoid physical activity, which can lead to weaker muscles and more pain. More pain can increase our stress and affect our mood, which further increases fatigue and our experience of pain, and on and on and on it goes. So our hope is to really break into this cycle anywhere we can, whether it be by addressing sleep, by addressing mental health issues, by stress management, exercise and physical activity, etc.
Great, thanks, Cynthia. And I'm really glad that you pointed out not only the physical symptoms, but also the fact that, yeah, from the perspective of function, as well as, mental health as well, how the impact of knee pain, osteoarthritis can really impact a person's life. So thank you for sharing those symptoms. And I think what the group on the call tonight is probably really interested in are the treatment options. So maybe we'll start with you, Cynthia, on the non-surgical treatment options for arthritis in the knee.
Sure. Okay. So what you see on your screen right now is the osteoarthritis treatment pyramid that is widely agreed upon among international researchers. However, most of these strategies can be applied to other types of arthritis as well. Now, the bottom of the pyramid, the darker blue areas, are the first line treatments for everyone with osteoarthritis. And this includes learning about your arthritis and self-management skills, as well as participating in therapeutic exercise and physical activity, and managing weight if needed. And these are the three treatments that have been shown to make the most difference for people with arthritis. That said, some may need additional treatments. So moving up to that lighter blue mid-level section there, things like medications, activity modification, passive pain treatments like heat or ice, and wellness strategies. Passive pain treatments may also include things like acupuncture, laser, or ultrasound, but there is really limited evidence of benefit for knee arthritis with any of those interventions, and the response is highly individual. Beyond that, some people may need referral for specialized management for things like injections or bracing. Only a small percentage of people will get up to the top of that pyramid where the joint surgery is. So not everybody ends up there. It's a small percentage that get there. And even though we start with exercise and weight management at the bottom of the pyramid, these strategies continue to be essential for managing your arthritis throughout your whole journey, even with medication or even after surgery. Now, moving back down to the bottom of the pyramid, I want to spend some time talking about physical activity and exercise. So there are four main categories of exercise: flexibility, strengthening, cardiovascular, and balance. And we encourage people to address all four categories in a weekly routine to the best of their ability. First of all, flexibility. This could involve range of motion for the joint, for example, lying on your back and bending and straightening your knee 10 times. This could also involve stretching the muscles around your knee, the quadriceps at the front of the thigh, or the hamstrings and calf at the back of the leg. And addressing the range of motion in the joint and the flexibility of the muscles can help to ease the pain, as well as improve mobility and ease some of the stiffness as well. Flexibility exercises should be done daily, ideally. Moving down to strengthening. This is incredibly important for knee arthritis. We want to build up the muscles around the knee joint to help absorb shock and take the brunt of the load so there is less irritation to the cartilage. Strengthening can also have a profound impact on your day-to-day functions, such as getting up from a chair or climbing stairs more easily. Strengthening typically involves some form of resistance. It could be ankle weights, TheraBands, lifting the leg against gravity, using body weight as resistance. And ideally, this is done 2 or 3 times a week. So every other day, taking a day off in between. Now, there are many, many different strengthening exercises, and they need to be targeted to your individual level and your starting point. They also need to be progressed as you improve so that you're constantly challenging your muscles. And don't just work the knee muscles. I also recommend you work the core and the pelvic girdle and hip muscles when you have knee arthritis, because weakness in those areas can directly impact the function of your knee joint. I do want to also highlight a particularly important type of strengthening called neuromuscular exercise. This targets functional movements like going from sitting to standing or stepping up, and involves conscious attention to alignment and technique. The idea is that you're retraining faulty movement patterns into ones that put less strain on your joint. Neuromuscular exercise is the key to the GLAD program, which is something that has been shown to reduce pain, improve function, and improve quality of life in people with hip and knee osteoarthritis. Next on the list is cardiovascular exercise. This type of activity is meant to get your heart rate up, your breathing rate up, good for overall health and quality of life, but also really great for your knee as well. We typically recommend low-impact cardiovascular activities for knee arthritis, things like cycling, walking, an elliptical trainer perhaps, or water exercise. The goal is to do 150 minutes per week in total, according to Health Canada guidelines. That time can be broken down into small chunks of time that are a minimum of 10 minutes. Ideally, aim for moderate to high intensity, meaning that you're going to have difficulty engaging in conversation while exercising. But a lot of people might find that difficult to achieve that goal when you have knee arthritis. So just remember that there's benefit to any amount of exercise, any time frame, even light intensity. Start with where you're at and make changes slowly towards your goal. And the last one on the list there is balance. So often when you have pain in the knee, not to mention weak muscles around the joint, balance can get affected. Add in the fact that balance declines as we age, and it is a recipe for falls. Exercise like Tai Chi has been found to be highly effective at decreasing falls in people with knee arthritis. On top of that, research has shown it decreases pain, increases function, and quality of life. Now, if you aren't sure where to start with exercise, you can access a physiotherapist in your community. Also, Arthritis Society Canada's YouTube channel has an excellent video of exercises for knee osteoarthritis if you need a bit of a starting point. That video can also be accessed on our website in the resources section under self-management. Now, a lot of people might be worried that exercise will exacerbate their pain or damage their joint further. So it's important to remember that hurt does not equal harm or damage is being done. However, pain is not something we want to outright ignore either. For osteoarthritis, we have some specific guidelines. For the other types of arthritis, there's a lot more nuance, and so it's definitely much more individualized advice. But for osteoarthritis, our guidelines are that during exercise, your pain should not increase more than 2 points on a 0 to 10 pain scale. So 0 would be you have no pain at all. 10 is the worst pain ever. So if you're starting your exercise program at 3 out of 10, it should stay below a 5. If you're starting at a 5, it should stay below a 7. The second part of that rule is that any increase in pain should settle in a couple of hours, maximum 24 hours. And if you follow those two rules, you'll usually be exercising pretty safely. If your pain is exceeding either one of those rules, it's a good idea to modify either the time frame, the duration, or the intensity of your activity, or pick something else entirely. As for things to avoid or not to do during exercise, first of all, make sure that you add, progress, or make your changes slowly. Don't force your joint position, like sitting on your heels or fully squatting. Avoid high impact activities. Avoid twisting and pivoting movements. And always pay attention to your technique and alignment when exercising. Now, when you're exercising, you may need to, or during even your day-to-day activities, you may need some modifications to help manage your pain. Activity modification is a really important way to protect your joints as well as conserve your energy. Some key strategies are to use braces. So having a knee brace may allow you to participate in activities with less pain or for longer periods. Use devices like canes, walking poles, or a walker. That, again, can help to reduce your pain, reduce your limping, allow you to participate more fully. Change your method. Think to yourself, could this task be done in sitting? For example, can I chop my vegetables sitting on a stool at the island in my kitchen rather than standing at the counter? Could I climb stairs leading with the less painful leg going all the way up? The other key strategies here would be to pace yourself and prioritize your tasks and plan ahead. So make sure you take some breaks during those challenging activities, plan ahead to where those breaks are going to be, and also spread things out over the course of the day or the week. And then very quickly, I do just want to talk about weight management, just to highlight that small changes can make a big difference. If you lose just 1 pound of body weight, that equals 3 to 4 less pounds of pressure going through your knees every time you take a step. That means if you walk 1 kilometer or 1,500 steps, there will be 6,000 less pounds of pressure on your knees with just that 1 pound weight loss.
Thanks so much, Cynthia, for that thorough overview of the non-surgical options. And now we'd love to move to Dr. Mark Roberts. And Dr. Roberts, I was wondering if you could share with us some of the surgical options that are available for knee arthritis.
Certainly. Thank you very much for having me. I thought we'd actually start by going through a little bit of how knees work, because it's very easy to feel that a hip, for example, because it can move in every direction, essentially, is quite complicated. And that really isn't the case so much, particularly when we're talking about doing things like hip replacements. So all we have to worry about from a long-term perspective is what we call adhesive wear, which is just the friction of that bearing surface. But they actually are relatively straightforward. A knee, on the other hand, is the largest weight-bearing joint in the body, and we tend to think of it simply as a hinge that bends backwards and forwards, and that's the function we get out of it. And unfortunately, that's not quite the case. And that has profound implications in terms of how natural things feel to us when you've had a surgical intervention. It has profound implications into what sort of interventions potentially are available too. So this closer up model shows the back of the knee. Now, either side, you can see what we call the collateral ligaments. The medial one, so the inside half of the knee, is formed of 2 parts, actually, one slightly longer than the other. On the lateral side, so on the bigger diagram there, it's the one closest to you. That is the one that attaches onto the top of the fibula there. And then in between the joint, you can see the menisci, so those shock absorbers that are very important as far as the function goes. And right in the center, that's your posterior cruciate ligament. We often hear about ACLs quite a lot because it's a common injury and has implications for the health of your knee going forwards. But we don't necessarily hear about the posterior cruciate ligament and its function. So ultimately, its function is something that we refer to as femoral rollback. And all that means really is as you bend your knee, the contact point between the femur, so your thigh bone, and the tibia, the top of your shin bone there, moves further backwards. So as we're bending, there's a translation that happens in the knee. And then if you look at the diagrams at the bottom of that slide, that's a representation of how much movement is happening on the inside half and the outside half. And what happens effectively is that the inside half doesn't move as much as the outside. So as you bend, not only do you have this shift in the contact point, but you also have a rotation. And that unfortunately has implications in terms of what we do with a joint replacement down the line as well. What I mean by that is if you push on a cushion, the part of that cushion that is directly under your finger is being compressed. But you're effectively producing a bit of a divot. And there'll be a little bit more talk about divots later on. What that means is the downslope, everything around where you're pressing is under tension. And if you move the point you're pressing on, so you move the contact point in the joint, then you've got an area that was being compressed that's now under tension, and an area that was under tension that's now being compressed. So in a knee, and particularly for a knee replacement, we have all these things going on during the movement that have implications in terms of how natural it feels for you, but also it's more than just standard wear and tear of the bearing surface. And that typically has had implications for the lifetime of the implant. So then if we go through a little bit of the progression here, I think this is important because it gives you an insight into what sort of things are more appropriate at different times in the journey. And we can kind of divide this a little bit into the wear and tear sort of arthritis, which is a gradual progression. And we have methods of quantifying this, if you like, and that's mostly so that professionals can talk about things. But there are also isolated traumas as well. So something happens and you take literally a divot out of the joint surface. Sometimes it's related to a blood supply, and there's a fancy term for that called osteochondritis dissecans. But ultimately, it can all lead to ongoing wear and tear throughout our life. And so that brings us on to the way we sort of look at treatment options. And there are procedures that we can do that are designed essentially to preserve the joint. And there are surgeries that we can do to preserve the joint. And then ultimately, then there are surgeries we can do to replace the joint or part of the joint, depending on what is more appropriate at the time. So the top part of that slide is looking at injections, which would be the most common interventional procedure that we would do in a clinic setting. And most of you have probably heard about having cortisone placed in a joint. Cortisone is essentially a very powerful anti-inflammatory medication, and as a depot preparation and right in the right place. And it can be highly effective in terms of reducing the inflammation in the joint and reducing your symptoms. And the knock-on effect of that, and this is everything that we really do in the field of arthritis and orthopedic surgery in particular, is all about quality of life. What can we do to maintain quality of life short of surgery, or if we have to go ahead to surgery? And all of those things require a consultation with your surgeon or your healthcare practitioner. And it's a joint decision, and that's because quality of life is an entirely unique thing. It's an individual experience. The things that you need to be able to do in your life to feel that you have a good quality of life is unique to you. And I will often say in a clinic setting, if we're going ahead with an operation, or we're talking about going ahead with an operation, is my role is really to say, this is an appropriate thing because your symptoms and signs and X-ray findings, etc., are bad enough. But the person who lives your life with your knee is you. And quality of life is a recurring theme here. It comes up in everything we do. Other injections, you may have also heard of lubricant type injections. That's what we call the viscosupplements. And there are combinations of viscosupplements and cortisone as well. And they tend to also be highly effective. There is more evidence for those things. And there are other injection type interventions that have less evidence, but probably more room to grow over time. So they fall in to a little bit of a, where is the future going? And those things can be things like platelet-rich plasma. So you have a sample of your blood taken and spun down in a centrifuge, and then a specific layer taken out and put into the joint. And there are stem cell type therapies as well. And the stem cells can be derived from different tissues. And again, these sort of technologies have a lot of promise for the future, but in terms of the evidence base here and now, it's not something that we particularly advocate on a large scale basis. We drop down to the bottom part of that slide, the little plate and screws there. That's something that we call a high tibial osteotomy. So this is quite an invasive thing. And the idea here is that if you've got significant arthritis that's debilitating, but you're young, and I don't mean young in your 60s or 50s, I mean young in your 20s, and you're sort of looking at the only option is a joint replacement, but the prospect of that is terrifying. One thing that does happen, and this particular type of procedure, what we call a medial opening wedge high tibial osteotomy, was developed at the Fowler Kennedy Clinic in London, Ontario. The whole premise is, whenever you load your limb, if you were to draw a line where the force goes, it goes from the center of your hip to the center of your ankle. And generally speaking, that will also pass through the center of your knee, unless you're wearing, in which case you start to bow primarily. And what we can do then is, if we, and this takes a lot of measurement and it's very carefully planned beforehand, open up a wedge in your tibia and tilt the leg. So we change the angle of your limb, then we're shifting some of that weight across to the good side of the joint. So if you like, we're borrowing some of the life from the side where the Teflon is still intact and offloading the side that's wearing. Now that's quite an intervention, and there's a lot of healing and rehab involved. But effectively, if that can buy you 10, 15, 20 years before you need something else doing, then that's quite a success story. And it's actually a relatively common thing to do, but earlier in the disease cycle, if the symptoms and radiographic findings happen to be that severe. A lot of the other surgical sort of options are often keyholes, so they're arthroscopic in nature. If we move to the next slide, there's a whole bunch of things here that you may have heard about when you're reading about arthritis. There are things like cartilage transplantation or cartilage culture and implantation. So there's something called ACI, which involves harvesting some of your own chondrocytes, so the cells in your own cartilage, and then culturing them in a lab and then injecting them back into the joint. And ACI is specifically under a little membrane that's covering a divot in the joint surface. MACI, M-A-C-I, involves a similar sort of thing, but what you get is a gel filled with your own cells that again is, it uses one of the clotting products. So it's a fibrin glue that's used to adhere that to the joint surface. You can do something called an Oates procedure, and that involves taking plugs of bone and cartilage from an area of the joint that you don't actually use and plugging them into an area where things have been injured and worn away. Microfracture is another technique that involves making very controlled little holes in the joint surface, again, in an isolated divot that allows marrow stem cells to flow into that and form a clot. And I think about that as being a little bit like cutting your skin. You bleed and you form a clot there. And ultimately what you get left with is a scar. It's not normal skin, but it's better than a hole. And this produces something called fibrocartilage, which is not the normal hyaline cartilage of the joint, but it's significantly better than having a divot there. And then the other niche things that you may have heard of are things like meniscal transplants, which, again, if you've done significant damage to the joint at a young age, then there are things that can be done to try to offload that, try to reduce the amount of ongoing wear and tear, and ultimately preserve the joint for as long as possible, and hopefully never get to the point where you need a joint replacement. The key thing about all these surgical interventions is the divot concept, because it's very much like taking a good chunk of the fairway out with a golf club. You can put that divot back in the hole, or you can fill it in with various things and level the surface again. But ultimately, what you need is a nice, healthy fairway around surrounding it. And the joint is the same as that. You need decent, healthy cartilage to support that intervention. So if you've got an isolated bit of damage to the joint, these are surgical options. And what we hope in the future is some of those will have extended applications when the arthritis part of things is getting worse and worse. But at the moment, if we're looking at more of a bare desert, a complete area of bare bone with nothing to support what you're putting in there, then unfortunately, they're not viable options once arthritis has progressed. Once we get to that point, once we get to the point where our wear and tear has got to bone-on-bone changes, significant bone spurs, those things we call osteophytes, then we're looking at joint replacement in terms of what we see on X-rays, and joint replacement if your symptoms are bad enough and the effect of those symptoms on your quality of life is bad enough. Joint replacements, we can divide them into partial joint replacements or total joint replacements. A partial joint replacement has some quite specific indications, and what you really need for the inside half of the knee, for example, is something called anteromedial arthritis. And what that really means is all of the wear and tear is at the front of the knee on the inside half. And the significance of it is when you bend and you have that femoral rollback, as we talked about earlier, if you're moving backwards onto healthy cartilage, then suddenly on an X-ray, if you X-ray a knee when it's bent, you suddenly see a joint space again. And it means that your ligaments are being kept out to length and kept healthy. And so a partial joint replacement is a good option. It also takes away significantly less bone. It's less invasive for the knee. Its recovery is probably a little faster. They probably feel a little bit more natural because all of the other structures around your knee are your own. It's common to think of it as being an earlier intervention, and I would caution against that. I think ultimately you need X-ray findings and symptoms and an impact on your quality of life that means you need a joint replacement. And then it's a question of, given those X-ray findings and the clinical findings in terms of examination, etc., which one is the most appropriate. So finally, we come to total joint replacement. And that effectively is resurfacing the whole of the joint. So there are metal pieces that go on the end of your thigh bone and the top of your shin bone, and then a plastic piece in the middle that forms the bearing surface, the bits that rub together. And they can either be cemented in place, as they have been for decades and decades, something called polymethyl methacrylate, that's bone cement, or they can be a press fit, they can be uncemented. And we've been using uncemented implants for hip replacement for a long time. It hasn't been typically as common in knees, but it is becoming significantly more common. And that's really kind of one of those things that's accelerating away now in terms of joint replacement. So the concept there is we're not gluing the components in, we're leaving them with a biological substrate. So it's usually a porous metal of some variety. The implant is the same otherwise, but that porosity allows your own bone to grow into those spaces. And that means you attach yourself to it. So that's one part of arthroplasty, the joint replacement piece, that is changing a lot at the moment. Ultimately, we can get to the point where things have worn away a little bit more than we would like. And this is not a common thing, but there are obviously options to deal with a lot of these problems. The X-ray there shows a right and a left knee, one significantly worse than the other, but both pretty bad in terms of the arthritis. And the right knee, which is the one you actually see to the left of the screen, is a good candidate for a primary joint replacement. And that could be a cemented implant, as you see at the top there, or an uncemented one, which is the top right as you're looking at it, implant. The other knee has got to the point where, and I don't usually see this, I often say to people, actually, you can't wear this knee to the point where you would change the surgery. And 99.9% of the time that's true. But occasionally we do see people who have managed to wear away not just the cartilage, but the bone too, and worn away so much bone that a regular implant won't fill that defect. And we have revision type implants for that scenario that have more fixation. So you see at the bottom there, that stem goes right down into the thicker solid part of the bone in the middle of your shin. So it gets extra fixation like that. And then we can add things called augments on it to make up for the defects. So the reality is, whatever the scenario, there's a reconstructive option. And again, that's all part of the discussion with your treating surgeon, if and when you're coming to making a decision to go down this pathway.
Great. Thank you, Dr. Roberts. A really thorough overview of all of those surgical options. And now I want to move us into a conversation just around what to expect and how to prepare best for surgery. So my first question is for both of you, but maybe Cynthia, we can start with you. What is your perspective on the things that patients can do to improve the success of their joint surgery?
Well, that's a great question. And as I talked a lot about initially, I'm going to talk about it again, but exercise is really key. So if you can think of it as kind of like your prehab, as opposed to the rehab that you're going to do after the surgery, you can do all of that conditioning and strengthening before the surgery. And we kind of nickname that prehab. So building up the mobility in the joint as best you can, the strength of the muscles around the joint, and that will enable you to bounce back a little bit faster after surgery. You'll also be familiar with all of the exercises that you're going to be doing after surgery. They won't be brand new for you. So things tend to go a lot more smoothly if you've put in that work ahead of time.
Okay, great. That's great, Cynthia. And working as a physio in a hospital as well, I think you've nailed it there in terms of exercise, and motion is lotion for sure. Dr. Roberts, anything to add to preparing for joint surgery for the best outcome?
Yeah, it's exactly as Cynthia said. The one thing I would add is joint replacement is quite a tough thing to go through. And going through all of the sort of pre-treatment options, those pre-surgical things, everything that you can do to look after your symptoms, etc., beforehand, is a very important part of the journey. Because if getting a good outcome, 95% of it is nothing to do with the operation at all. It's your hard work and the physiotherapist's hard work. And the motivation to do that in a large part, I think, comes from being certain that you're making the right decision for you. And that comes from having been through all those things and effectively ending up at a joint replacement because there are no other options to maintain your quality of life.
Right. No, thank you. Yeah, it's definitely an individual journey and everybody's different. One last question? What, Dr. Roberts, would someone expect? You mentioned it's not easy. What are some things that somebody could expect after joint surgery?
Well, ultimately, it's a journey. To put it in sort of a timeline, if you like, it's quite common now, increasingly common for it to be a day surgery procedure. Not universally, but that's the trend. But whichever day you go home, the likelihood is you've got a lot of freezing in the joint. You may have a nerve block as well. And so pain early on, the first 24 hours or so, usually is not too much of a concern. But that means taking your painkillers beforehand is one of the most important things you can do, because playing catch up with pain is much, much harder than staying ahead of it. And when you're on more of an even keel after that, and you know you can do your exercises, etc., then you can start to think about when's time to wean down the heavy hitting, the stronger painkillers. Usually it's about 2 weeks for the wound to heal. So you're often seen back in the clinic at that point. And usually by about 6 weeks, we want to have got most of your motion back. And the one thing I typically say to everybody is, you can't hurt the implant. You can only hurt yourself, and that's okay. Not because you're trying to torture yourself, but it's very common to think, this is hard, it hurts, I must be damaging something, and you're not. It is important to make sure that you're managing the pain to the point where you can do your exercises, because again, getting a good result that's everything. I think those are the most salient things. In terms of the overall journey, it's very common for people to feel that being active is a good thing. And it is, but it has to be a little balanced, and you have to listen to your knee. Because if you do a lot of walking, for example, then you may end up with a lot more swelling and discomfort and then find it quite hard to do your physiotherapy exercises. And that's a bit counterproductive. And it's easy to get into sort of cycles of poor pain control. And ultimately, what we want is for this thing to function properly for you and enable you to do all of those things that you want to be able to do in life.
Right. Okay, thank you. No, thanks for taking us through that journey of what to expect. One last question just about the future. I mean, our future is rapidly evolving in all sorts of areas, healthcare being one of them, and obviously our orthopedic surgery being one of them. So Dr. Roberts, maybe we'll start with you. What excites you about the future of research, innovation, and treatment for people diagnosed with knee arthritis?
Yeah, there's a few things here. Stem cell therapy we touched on earlier. To me, that's quite an exciting thing. And it's because it's a very young technology and there's an awful lot of room for it to grow and develop. So I don't think it's going to have a significant impact within, say, my practicing life. But I don't think it's hyperbole to say that maybe in my lifetime, there won't be joint replacements. I think it has that much potential. The other stuff on the screen here, that bottom left picture is a press fit type knee. So there's an awful lot going on now in terms of those uncemented options for developing implants, and the implants developing to, again, feel more natural. The other stuff that's happening at the moment is we're trying to make things much more efficient. So traditionally, knee replacements have involved pans and pans of instruments that all have to be washed and re-sterilized, etc. And that takes time to open and time to clear up. The bottom right picture there is everything we need for a joint replacement in my hospital. So by using advanced digital templating and having much more of an idea of the sizes of implants that we're going to be using, we can tailor the instruments so that we're cutting down the time it takes to set up, the time it takes to reprocess the room. There's a significant cost saving involved, and all of that is geared towards us being able to treat more people. The other things that are happening is things like robotics, and you may have heard a lot about that. It's again a new thing. It's in its infancy. It's an extrapolation of computer navigated technology. And the big thing here is not that it's going to dramatically change the surgery itself. So I don't want anybody to think, well, I'm not having a robotic assisted knee replacement. Maybe that's not as good. You're having a knee replacement by a highly skilled surgeon who's done thousands of these procedures, and you will do very well. The big thing here is the data, because for the first time, we're standing on the brink of being able to say, well, this is how a knee was. I can put your knee through a range of motion and see what the ligaments are like and see how your knee behaves. And we can get knee scores from you. So you fill out a questionnaire and we get an idea of how you're doing. And we can see how you were, what we did, how you were afterwards, and ultimately how that translated into increasing function and pain relief, etc. And there are unanswered questions in terms of the surgery itself and the evolution of implants and alignment philosophies and all sorts of things that ultimately you need the data to answer those questions. So the AI piece that's coming, I think, is really quite exciting from a surgical perspective. The other thing on the bottom left there, that's a smart implant. So there's a stem that goes on the bottom of that knee replacement that can give real-time data about the knee cycling and the loads going through it, etc. And again, that sort of smart implants combined with AI and data collection, I think is going to be a game changer going forwards.
Fascinating. Yeah, things have advanced so much and so much more. And to hear you speak about the fact that as an orthopedic surgeon, we may not need these surgeries in your lifetime, it is quite fascinating. And I think it's definitely heading in that direction. Thank you for sharing that. I think we want to move right into the questions. We've had so many questions, a lot of interest, and we're going to start with some questions that were submitted prior. One of the themes, and Cynthia, this question is for you. One of the themes that emerged in our questions was around falls. So in particular, people, are asking questions around having trouble getting up after a fall due to pain in the knees. Do you have any recommendations around knee pain, falls, and also, maybe getting up after a fall if that were to occur?
Yeah, I think this is a case where prevention is the best medicine, really. And so if you're recognizing that you're at high risk for falls, you can get yourself to a fall prevention program, exercise program. Tai Chi, like I mentioned, is really great, has proven evidence for reducing risk of falls in people with knee arthritis. And so that would be my number one recommendation. Number two, again, if you're high risk, you may need to get one of those buttons that you can push to call for help when you fall. Other than that, I usually say if you can get yourself over to a piece of furniture, it will make it much easier to get up. But before you try to get up, you need to make sure that you're actually okay and haven't injured some other part of your body, hit your head, twisted an ankle, or maybe broken a bone or something like that. So before you even try and get up, I think it's best to kind of sit for a moment, take stock, figure out if you're okay to even try and get up or not. But if you feel like you are, I say get out, kind of scooch over if you can towards a piece of furniture and use that to help you get up. But it's definitely a challenge. So this is, again, prevention is the best medicine in this case.
Okay, great. Thanks, Cynthia. Dr. Roberts, a lot of questions around knee replacements and whether or not they should be both replaced at the same time if both knees are affected or not. Could you talk us through the pros and cons of having both knees replaced at the same time?
Sure, that's a great question. I think the reality for that is there's no risk-free surgery. And so doing both at the same time inevitably increases the risk. The potential gain is obviously that you get on with life again because rehab-wise, you get to the end point of function sooner. There are specific kind of things that we look for in terms of the amount of deformity in a joint that sometimes mean it's a sensible thing to discuss. But by and large, what we try to do is stage them. And that, again, is a unique thing to an individual, but you want them as far apart as possible, so it's as safe as it can be and you're as recovered as you can be, but also kind of as close together as possible so that you get both done and get on with things. And an ideal balance seems to be around 3 months, something like that, if both knees are symptomatic enough that they need doing. But again, it's very individual. If you want to push it, 6 weeks is reasonable without increasing the risk too much. It's just a little harder. But some want them 6 months apart. Some people would prefer one this year and one next year. It's a very unique thing. And again, a discussion with your surgeon.
Okay, great. Thanks, Dr. Roberts. Cynthia, back over to you around a lot of questions around knee braces. So are knee braces, are they effective in relieving pain? And if so, are there any specific knee braces that you would recommend as a physiotherapist?
Well, there's many, many different types of knee braces. So some are more effective than others is kind of the short answer. So the bottom end of the scale would be a simple compression sleeve. So something kind of like a tensor bandage that you would pull on over top of your knee. That can be beneficial for some people. Just having that compression can sometimes decrease a little bit of the pain that somebody's experiencing. So it can provide some comfort. It's not stabilizing anything. It's not changing the arthritis in any way, but it may provide some comfort. You can go up from there to things that kind of wrap around and Velcro on that have, some either plastic or metal supports down the side and some hinges that have a little bit more support. Again, really the only thing that has evidence of benefit is what they call an unloader knee brace, which is designed to almost like the surgical tibial osteotomy that kind of changes where the pressure is going on the joint. This brace kind of does that same thing. Very expensive, custom-made brace, but that is the one that can be helpful when you have arthritis primarily on the one side of the joint. So typically, if it's primarily on the inside half of the joint, then you can kind of offload that side of the joint and get some pain relief and potentially slow down the progression of the arthritis.
Okay, thanks for talking us through that, Cynthia. Dr. Roberts, obviously we talked about the advances in joint replacement surgeries, and we wanted to ask a question about the life expectancy of an artificial knee, which I suspect has improved over years. But right now, what would somebody expect if they were to get a knee replacement? How long would it last?
It's a great question. It's a difficult one too, because we follow these things along in the joint registries, and there are some big registries around the world. And so what we're looking at now is the sort of things that were done 20, 25 years ago. And what we think is that that's what you could reasonably expect from a joint replacement at the moment. That's a ballpark. And you also have to remember it's one of those bell-shaped curves. So most people seem to be getting 20, 25 years. Some people will get 40, and some people might get 10. And those will be the minorities. The bulk of people can sort of aim for that ballpark. But what we're doing today, we think is probably better, but we won't know until we follow them along for another 20 years or so. And the impact on, people skiing and doing all these activities on them now compared to the sort of expectations that were had years ago is also something that's more of a watch this space thing, I think.
Okay, no, that's a great way to frame it. Thank you for that. Cynthia, another question for you around exercises, and I'm going to kind of combine a question that came in prior as well as one that came in on the call. There's a pickleball craze. Everybody, pickleball is very popular. So I think there were some questions around, is this bad for your knees? And maybe if you could answer that and maybe to share what could be done during pickleball to, maybe reduce potential pain, but also any other specific sports or exercises as well that you would recommend to slow down OA progression.
So I think it's really individual. And so it depends how your knee feels, I think, while you're playing pickleball during and afterwards. And if you're not experiencing any exacerbation of your pain or other symptoms, I wouldn't be worried about it. The one potential drawback, I'm not a pickleball player. I'll put that out there right now. So I would be worried potentially just about any kind of quick side-to-side movements, those pivoting kind of sharp twisting, sudden starts and stops, and that sort of thing is the only one thing that may just cause some strain on the joint and potentially irritate things. And as Dr. Roberts mentioned earlier, we just really want to keep that pain level under control, keep the swelling under control so that you can still do your day-to-day activities, your exercises, and the things that are important to you. And so we don't want you to just create more and more pain and more swelling to the point that you can't get off the couch anymore. So the main thing is to keep that pain level manageable. But if pickleball is something you love doing and it doesn't exacerbate your symptoms, then by all means, I would keep doing it. And what was the other half of your question, Sean? I've forgotten.
So are there, like you mentioned, exercise, right? And the
Yeah.
benefits of it. Are there any specific, I mean, quickly in the time we have, even one or two of the top exercises that people could do to prevent or to manage knee osteoarthritis?
Honestly, walking is the easiest thing. So your cartilage needs moderate load in order to stay healthy. So moving and using your joint in smart ways, right? Not overusing it, but in smart ways. So moderate load actually helps to give your cartilage the nutrition that it needs and to keep it healthy. And walking is a really great way, easy, cheap, inexpensive way to do that. And so that's kind of my top choice for a lot of people.
Okay, great, simple, thank you. Dr. Roberts, maybe a couple quick last minute questions before we have to close tonight. One is, and they're around kind of diseases combining. So some questions around osteoporosis and arthritis. And this has come up a few times in the Q&A. And are steroid injections into the knee contraindicated if you have osteoporosis? Some people that inquired about this were worried that injection could weaken or weaken the joints or the bones around the knee.
But that's an easy short answer. The injection's into the joint. It doesn't do anything to the bone. So there's no contraindication. You're much better being able to manage your symptoms so you can stay active, because that weight-bearing exercise is better for your osteoporosis.
Okay, good, easy answer. The next one is around hip and knee replacements. So similar to your answer, or similar to the question around doing both knees at the same time, if you have hip osteoarthritis and knee osteoarthritis, is there an order that they should be done in from your recommendation and from your experience?
So there are really two principles at play there. And again, this comes back to quality of life. So the first thing would be, which one has the biggest impact on your quality of life? Because this is a big differentiator, then that's the one I would go to first. By and large, however, particularly if they're sort of equally symptomatic, we would start at the top. So we would do the hip first. And because there is a degree of innovation, so nerves going to both joints, it's not uncommon for the knee symptoms to be largely due to the hip. So doing the hip itself can mean that you don't necessarily need anything doing for the knee.
Okay, great. Thanks, Dr. Roberts. One last question I think we have time for, and Cynthia, I'm going to put this one to you because I think it expands on your walking advice. We did have a question come in tonight around walking poles, and just interested to know your thoughts on the use of walking poles while walking. Are there any recommendations, the type, or just any of your thoughts on that?
I love walking poles. They are fantastic for knee pain, hip pain, lower back pain. They're great. So definitely highly recommend them. They can take a little bit of getting used to. So I do recommend look for maybe a class in your community that teaches you how to use them properly, because there's some coordination involved. It's really great if you've got arthritis in both lower limbs, because then you get the support for both sides when you're using the walking poles. But it helps with your posture to keep you a little bit more upright, as well as taking some of the strain off the joints. Good cardiovascular workout because you're using the arms as well. I really like the activator poles for people that have arthritis. So they're built a little bit differently than maybe some of the Nordic hiking poles are built, and they're really designed with a rehabilitation frame of mind. And so that's my personal favorite brand.
Okay, thanks, Cynthia. Again, thank you, Cynthia and Dr. Roberts, for sharing all of your experience and knowledge today. It's been super helpful. We've covered a lot. We would like to take a few moments to get your feedback as an audience today on the presentation. So for those of you watching on Zoom, you will see a poll question come up on your screen with answer options. So if you see that pop up, if you could click the response that reflects your thoughts. The first question is, I feel more knowledgeable and empowered after attending this webinar. And whether or not you strongly agree, you're neutral, disagree, or strongly disagree. So you'll see those options. So we'll start with that question. And I'll give you a few moments. Okay, thank you for taking the time to answer that poll. We also will be sending you a full evaluation form through email with the recording and the slides. So if you're unable to access the poll question tonight, you will have the opportunity to share feedback with us. The feedback is very important for us to inform future sessions and opportunities for Arthritis Talks as well. So it's great to have your input. Arthritis is the leading cause of joint replacement surgeries, including 99% of knee replacements are due to osteoarthritis or arthritis in general, and more than 70% of hip replacements. So as many of you know, people are waiting way too long for these life-changing surgeries, and we do need your help in urging the government to take action. I know we had questions tonight about the wait times, and it is a challenge. So if you could go to arthritis.ca/wait times and add your voice. This is something that we're very passionate about at Arthritis Society Canada. We really want to see this change and provide joint surgeries earlier for people that need them. Once again, we are grateful to Pfizer, United Way Winnipeg, and our other partners for their financial support of this event. We hope to see you at our next Arthritis Talks, which is focused on medical cannabis. This session is on November 6th. So for more information, it will be available in the email that we're sending to you tomorrow. This concludes Arthritis Talks for this evening. On behalf of all of us, we would really like to thank you for participating and for joining today, and stay well. Thank you.